Okay, so welcome to this ISBNPA webinar on health inequalities. This is hosted by the Special Interest Group for Health Inequalities, who's chaired by Anya. And today we have Frances Hillier-Brown, who's kindly offered to present on the effects of public health interventions for reducing socioeconomic inequalities in obesity. Just to give you a bit of background on Frances's career up to now, she's been working in the field of obesity and obesity-related behaviour for around 13 years now, gaining a PhD in 2011. She's worked on a large number of multidisciplinary projects funded by the likes of the World Cancer Research Fund, the UK Standards Food Agency, just to give you a flavour of her background, and is also an experienced systematic reviewer and is interested in the development and evaluation of complex obesity-related interventions. There's a particular interest, I think, there in methods and the synthesis of evaluation methods, especially in relation to sort of physical activity and diet-related behaviours. And I think for today's session, we have a wide range of different people from different backgrounds, from academics to local authority. And what I'd ask you to do as we go through the session is to, there's a chat function just at the bottom of your page, and a question and answer function as well. So as we go through the webinar, what I'd encourage you to do is to ask questions, and then at the end, we will then have a list of things that we can ask Frances as we go through. So there's no reason to wait until the end. You can put the questions on as we go through, and then that will allow us to have a concise discussion at the end. So I will thank once again Frances for presenting and hand over for your presentation. Thank you.
Okay, well, thank you very much, Matt, and thank you very much for inviting me to talk today. So today I'll be talking to you about socioeconomic inequalities and obesity, and how public health interventions aimed at preventing and treating obesity may be affecting these. Okay, so just to run through what I will be talking about today. So I'm going to start off with some data on the prevalence of socioeconomic inequalities and obesity to sort of paint a picture of the current problem. I'll then talk about causes of health inequalities, as general health inequalities, and also approaches to reducing those. I'll then move on to talk a little bit about intervention-generated inequalities, and that will bring me to the sort of main part of the talk today, which is around a systematic review that I conducted on the effects of individual, community and societal level interventions at reducing socioeconomic inequalities in obesity. So this is looking at potentially whether these interventions are causing intervention-generated inequalities. I'll then talk a bit about some related work, and then touch on some research and policy implications. So let's start off with the problem of socioeconomic inequalities and obesity. I am based in the UK, so I am more familiar with the data from here, but I promise I will look at some international data a little bit later too. But starting off with the UK, the problem of socioeconomic inequalities and obesity has been known for quite a while now. This report, published over 10 years ago, showed that there was a clear socioeconomic inequalities and obesity, and these have been apparent for the previous 15 years, although on the positive side they did not appear to be widening. A recent systematic review of cross-sectional studies found that common area, household and individual level indices of socioeconomic position were generally inversely associated with childhood obesity. And Claire, Bamber and colleagues found that this relationship was more clearly demonstrated in women, and they found that 10% of obesity in men and up to 33% of obesity in women is attributable to socio and economic inequalities. This is also demonstrated by the Health Survey for England data, where the gap between obesity levels in the lowest social class, hereby employment category, and the highest is much greater in women compared with men. And in line with the report by White and colleagues, the gaps in both men and women have remained fairly consistent over time. So while not widening, they certainly do not seem to be going away. You can also see that the problem isn't just between the lowest and the highest social groups, but there is a gradual increase in obesity as social class becomes lower. And these data from our National Child Measurement Programme shows this gradient even more clearly. And this shows that obesity prevalence in the most deprived 10% areas in England is more than twice the prevalence in the least deprived 10%, but obesity also increases along the SES gradient. So why does all of this matter? We've seen that obesity is associated with increased risk of chronic diseases such as cardiovascular diseases, type 2 diabetes, and a number of cancers. And these all contribute to shortened life expectancy and, possibly more importantly, healthy life expectancy. And I was reminded of these figures just recently at a really good talk by Tess Kay from Brunel University, showing that the difference in life expectancy is almost 10 years between men living in the most deprived areas of England and those living in the least deprived areas. This difference is slightly less for women at nearly 7.5 years. But more striking is the difference when it comes to healthy life expectancy at 18.5 and almost 19 years for men and women respectively. So I promised some international data as well, and this is some data from the Southern Hemisphere in Australia. And again, the trend seems to be consistent in adults where obesity levels increase as deprivation levels increase. And interestingly here also the obesity rates seem to be highest in men. And again, this is fairly consistent in children, although the trend isn't quite as clear-cut as the UK data shows. The picture is also similar across Europe, and here we're looking at overweight obesity levels by education. And you can see that the pattern is similar across countries, although it does vary slightly between them. The prevalence in looking at the percentages of obesity which seems to be attributed to inequalities, in this case in education status, you can see these are actually a lot higher than the figures that Bambara and colleagues calculated, with 26% of obesity in men and 50% of obesity in women being attributed by inequalities in education status. So the between country difference may be explained by this figure by Pickett and colleagues that shows that among women in high income countries, the wider the gap between the populations in terms of those with the lowest income and those with the highest income, the greater the prevalence of obesity. And you can see the USA there right at the top of the corner, which obviously has the widest gap in income and also the highest obesity rates. And this is some more work that's compared a number of different high income countries. And these show differences in the SES inequalities between countries. And again, this also shows that the difference here is more pronounced in women, and this trend seems to be something that is the case internationally. Okay, so we can see that there are clear differences in obesity level depending on socio-economic position, and these contribute to health inequalities as a whole. So one of our leading experts in health inequalities, Professor Dame Margaret Whitehead, describes health inequalities as systematic differences in health between different socio-economic groups within a society. And because these are socially produced, they are potentially avoidable and widely considered to be unacceptable, in civilized society. So now I'll just talk about some of the causes of health inequalities in general, and I'll talk about some of the sort of three main theories behind these causes. So the first theory I'm going to talk about are the behavioural and cultural model. And this shows that differences in health-related behaviours seem to cluster within certain social groups. And this may be because of characteristics in the groups or because they're culturally more acceptable. And you can see in this graph that and this is a measure of a healthy index. So this is a cluster of various different health behaviours, such as healthy eating, alcohol consumption, physical activity, smoking, etc. And you can see that the healthy lifestyle score increases as deprivation, it decreases. So we have the least deprived areas showing the highest scores compared to the most deprived areas. But within these, we can see a kind of an interaction with individual level socio-economic status. And here they've used occupational social class. So you can see that even within the least deprived quintile, if you are at a quite low have quite a low occupational social class, this doesn't protect you so much against the area that you're living in. So there's a kind of two-way interaction here. Another cause of health inequalities is thought to be the environment that a person lives in. And there is growing evidence to suggest that deprivation, as deprivation increases, so does access to affordable, healthier food and physical activity conducive space. And here I've used an example of fast food outlets, and this is a graph from some data in England that shows how, as deprivation level of an area increases, so do the number of fast food outlets. And the graph on the right by Thomas Burgoyne and colleagues show that obesity levels by quartiles of work and home-based fast food outlet exposure, with the first quintile being the least exposure and the fourth being the most, shows that obesity increases as this exposure increases. But again, it also shows this sort of two-level interaction as well, in that at the individual level, here again, SES is measured by education level. The effects are stronger in those in the lowest SES, and are protected to a certain extent by those with a higher education. And then finally, the psychosocial causes of health inequalities. This could be, I think in my opinion, is a really strong factor. And this shows how social inequality makes people feel and how then that has consequences in their behaviour. And living in lower, in deprived areas, having insecure jobs and work pressure is very stressful. And this study that's come out of the Whitehall cohort has shown a dose-response relationship between work stress and risk of obesity, and showing that the risk of obesity increases even at just one period of work stress. And the evidence also shows that work stress is much higher among those with lower SCS, as the type of work they tend to do are jobs with high demand but very little perceived control. And this figure here gives a nice illustration of how inequalities can compound across the life course as well, starting from pregnancy, moving through childhood, adulthood, and then later health problems. And here this shows in some places a bit of a chicken and an egg situation, and a vicious circle whereby individuals born into a low SCS environment tends to affect sort of their later life choices, and in the case of, say, employment, they're more likely to have kind of low paid repetitive jobs that are inflexible. And getting out of this vicious circle can be really difficult. So there's been 4 approaches to reducing health inequalities have been proposed. And the first of these is focusing on improving the position of the most disadvantaged groups, and this is what we would call a targeted approach. The second approach is where interventions aim to reduce the gap between the best and the worst off, potentially actually decreasing the health of the better off groups. The third approach, as we've seen from the data, there's a clear social gradient in obesity inequalities. So the third approach is one in which aims to reduce the obesity levels across the entire social gradient and to sort of level off that gradient. And then the fourth approach is a kind of combination between 1 and 3, whereby interventions aim to tackle whole populations following a universal approach, but may have more targeted elements at those most in need, those in the most disadvantaged groups. And there are also different levels at which interventions can be targeted. Traditionally, obesity interventions have been more focused at the individual level, but there is definitely general consensus that we need more interventions that target those environment and societal levels, i.e. those more upstream interventions. So now moving on to the concept of intervention-generated inequalities. And there is that sort of fear that interventions that aim to improve health, particularly public health interventions that aim to improve health of whole populations, may actually be causing more harm than good, and are only taken up by those more affluent groups that possibly don't need them as much as the lower SCS groups. So this review that was published in 2013 looked at the evidence around what types of interventions may cause increased widening in socio-economic health inequalities. And they found that media campaigns and workplace smoking bans show some evidence of increasing inequalities between socio-economic status groups. So these tended to be the intervention-generated inequalities. However, the more structural workplace interventions, so the provisions of resources and fiscal interventions, such as tobacco pricing, showed some evidence of reducing inequalities. So the authors concluded that their findings were consistent with the idea that downstream preventive interventions are more likely to increase health inequalities than the more likely to increase health inequalities than the more upstream interventions. However, they also did note that the data published on intervention-generated inequalities were lacking. So why might interventions such as media campaigns not work? Well, this type of intervention often works by using an education or information provision support. And these types of interventions rely heavily on the effort being made by an individual, or in other words, the individual requires high levels of agency. So this is a lovely illustration created by Jean Adams and colleagues, and it compares the efforts or steps needed for changes to be made between a typical information provision type intervention, and here they talk about a leaflet, but it could be something like a TV advert or a website, versus a more structural change. And in this case, they use the example of food fortification. So as you can see by the top steps, you can see that the information leaflet requires a number of different steps to be taken by the individual before the desired behaviour change is made. And at each of these steps, the individual can drop out of the process. But the bottom example showing the structural change, so here we've got folic acid added to flour. There is just a one-step process, so the participant either chooses to purchase those and consume those products or they don't. And this is a much sort of easier, more direct link to the desired behaviour. So in summary, when we're looking at reducing socioeconomic inequalities in obesity, we know that the causes of obesity are very complex. We need a whole systems approach that tackle the wider social determinants of health, and that we need those community and societal approaches along with individual. We have, as you can see, we have a lot of data describing the problem, but we now need to provide the evidence that goes beyond this and provide the evidence behind what may reduce these inequalities. So this leads me to our systematic review, and we looked at a range of different levels of public health interventions that were aimed at preventing or treating obesity, and we looked at the effects on reducing socio-economic inequalities in obesity. So we have a number of different outputs from these reviews. So if you're interested in finding out more, do look them up. But our research objectives were to systematically review the effectiveness of these interventions at reducing socioeconomic inequalities amongst children and adults. But we were also interested in how these public health interventions were organised, implemented and delivered. We conducted the systematic review using a number of standard methods and procedures to try and ensure high quality. So we did duplicate screening and data extraction checking, for example. We assessed the quality of each included study, and we used this along with study design to actually identify the best available evidence within each category of intervention. We searched 9 databases and also looked at various relevant websites, and we did some grey literature searching. So before we started the interventions, we developed a framework in which we theorised where the different types of interventions might sit. And here you can see how they might actually target the different causes of health inequalities, so your behavioural, psychosocial, material and environmental. We had a relatively inclusive inclusion criteria. Basically, we were interested in any type of obesity intervention that was either targeted at a low SES group or one that explored differential effects by SES. By experimental studies, we meant controlled trials, and by observational studies, we meant any longitudinal study, any other longitudinal study design. By targeted intervention, we meant those interventions that were delivered at low SES groups only, and therefore follow the disadvantaged approach to reducing health inequalities. And universal interventions were those that were delivered across whole populations. So as I said, we used the Effective Public Health Practice Project Quality Assessment Tool for quantitative studies to rate all the included studies, giving them a quality rating. And we use those along with the study design to create this hierarchy of best available evidence, with the best available evidence being experimental strong quality studies, and the sort of least best available evidence being those that were observational, had an observational study design and were rated as weak. But for some of the categories, this really was the best evidence that was available. So we used quite broad search terms, and we didn't filter for SES at the early screening and staging and screening stages, because actually we found, or we knew that in a lot of studies, the actual analysis or results around differential effects could be quite hidden sort of deep within the paper. So we didn't want to exclude any like that at the abstract stage. So we ended up with quite a large number of hits to filter through. But we got through them and ended up with 43 best evidence studies. And these were divided into child and adult studies, and then by category at the different levels. So we had individual, community, environment and policy interventions. And we also identified a multi-level intervention as well. The majority of the studies were categorised as community studies, and we defined these as group-based interventions or interventions delivered in a community, workplace or school setting. And these were often education-based interventions, as any intervention that involved an environmental aspect, so provision of sporting facilities, changes in cafeterias, we actually categorise those as environment interventions. So this graph shows when each of the included studies were published, and this shows an increased trajectory over the more recent years. And this probably reflects the increased awareness of and interest in reducing health inequalities. So the evidence behind for the individual level studies came from strong quality experimental studies. We found that universal screen time reduction interventions were more effective in low SES children in the short and long term. And by short term, we mean around 6 months or less. We found that targeted mentor-based health promotion approaches were effective in overweight and obese children. And tailored weight loss programs delivered in primary care targeted at low SES adults were effective in the short term. As mentioned earlier, we found most evidence for community level interventions, and these also came from strong quality experimental studies. In children, universal school-based nutrition and physical activity education, along with exercise sessions can be effective across the whole social gradient. Targeted family-based education and behavioural weight loss programmes and group-based exercise interventions were effective in the short term. And in children, we found evidence that education-only approaches were not effective. In adults, targeted community and workplace-based nutrition and physical activity lifestyle counselling can be effective, as can professionally delivered behavioural therapy, again targeted at low SES groups, in the short term, but these effects were not sustained. At the wider level, much less evidence was found, and in some cases our findings were based on just single studies, and the quality of this evidence tended to be weaker best evidence. In terms of the environmental studies, we found that a study in children that incorporated school environment changes had equal effect across the social gradient. However, an environmental intervention in adults had adverse effects in terms of inequality. We found one study that had strong elements across each category, so we coded this as multi-level. And this was a strong experimental study that found evidence of a community capacity building intervention, and this prevented a natural widening of SES inequalities in obesity in children. So at this level, there are clearly some evidence gaps, and there were actually no macro policy type interventions in children being identified. And here we mapped our studies according to our framework, and we actually found a different pattern to what we proposed. But what it really clearly shows is the gap in understanding differential effects of macro policies, and that is shown in the child studies and the adult studies. So overall, we found little evidence of any adverse inequality intervention effects. We found that school, community and work-based education and behavioural interventions were found to be the most effective in reducing inequalities. However, evidence was dominated by individual and community, not environmental, level interventions conducted in the USA and limited to children aged 5 to 11 years and female adults. A few studies seem to be specifically designed to measure inequality differential effects, and actually the majority of the interventions were those that were targeted, so only include low SES populations. And few of the universal interventions seem to be specifically designed to reduce SES inequalities in obesity. And this is the sort of information we found when we were looking at how these interventions were implemented. And finally, we found that the number of studies that we included in our review actually represented a very small percentage of the total obesity prevention and treatment interventions that were out there, and we identified around 2,000 of those. And we actually did see, or we noticed that a lot of these interventions did collect the SES data, and this was often reported in baseline tables, but they just hadn't gone that extra step in the analysis, so they hadn't looked at differential effects across these measures of SES. So at about the same time, so when we started our review, there'd been nothing else really of that kind that had been done. But when we published our review, there was actually a similar review that was published around the same time. And this was a review by Beauchamp and colleagues. However, they only included interventions that looked at differential effects by socioeconomic position. So they didn't include what we called our targeted interventions. And their findings supported the notion that the more upstream interventions were more effective in lower socioeconomic position participants. And then a couple of years after that, Olstad and colleagues conducted or published a review of policy level interventions, and they stressed the importance of ensuring policies had a structural element as well as those that relied on individual effort. There are also a number of reviews that have looked at intervention effects on inequalities in obesity-related behaviours, so diet and physical activity. And there's a few of these that now exist that I won't go into in detail, but that you can have a look at. But what all of these reviews generally found, they backed up our finding that there appears to be a lot of studies out there that may contain suitable data, but again haven't gone that extra step in the analysis. So it could be that there is some sort of untapped data sources out there that could fill in some evidence gaps. So finally, in terms of related work, I just wanted to give you a heads up on some work that I've been involved in recently that hopefully will be available soon. And this is our abstract that was published in the Lancet Journal last year. And we've just returned minor revisions on the full paper. So this work was a review of reviews of the effects of public health policies on health inequalities. So this was health inequalities for public health as a whole. So we did include an obesity element, but we also included other public health issues such as smoking, alcohol consumption. And so this again contributes, this paper will contribute to the evidence of what might be effective in reducing health inequalities. But what it did show was a distinct lack of policy level evidence in terms of what might reduce inequalities in terms of diet and physical activity behaviours. So what I want to just sort of end the presentation on is just some consideration of what these implications or what these studies might or what this topic has in terms of implications for research and policy. And what can we do as researchers? So for those involved in both evidence synthesis and intervention development, I think what we need to do is to ensure that we consider health inequalities in everything that we do. So this could be looking for this specific evidence or trends in the evidence when conducting reviews of intervention studies. And even if this is just a subsection of your review. And when developing interventions, of course, we need to ensure that interventions don't lead to a widening of inequalities, but we also ensure that there are methods that can monitor this, and ideally ensure that studies are powered to detect these differential effects. And when reporting studies, we need to ensure that any of these considerations or differential effects are clearly reported, even if it is just in supplementary material. And there are the groups and guidance that can help with the reporting and guidance on pulling out this information when reviewing the evidence. And then there's something else in terms of research that I think is important to consider when looking at differential effects of interventions, as actually just looking at overall effects only tells us part of the picture. And we want to know, actually, is the intervention reaching and engaging the right people in the first place? Is there an inequality before an evaluation or intervention even begins? And this information even more is lacking from the sort of published papers and reports. And I'll just demonstrate this using an example from another study I've been recently involved in. And this was just a very small piece of work. It was a feasibility and acceptability study of some training that was provided by one of our local authorities in the northeast of England, and this training was provided to owners and managers of takeaway food outlets. So all takeaway food outlets with a certain hygiene rating were invited to attend the training. And encouragingly, the proportion of food outlets located in the most deprived areas of the local authority that were interested in attending the training was representative of the total eligible population that were invited to come along. So it wasn't just the owners and managers from businesses located in the more affluent areas who were interested. Where things start to become a bit skewed is when we started collecting our data and tried to follow up with the businesses. So as part of the training, the owners and managers were asked to set goals and that they would try and work to. And when we contacted them 6 weeks after the training, we wanted to see how they were progressing with their goals and see if they had achieved them or not. And here we found that the dropout rate was higher in the businesses from the more deprived areas. And we were just unsuccessful at making contact with these owners or managers, and we tried numerous times, but were unable to collect data from them. So therefore, it could be assumed that these businesses probably didn't engage with the intervention and probably didn't achieve their pledges, and therefore intervention was potentially less successful in these businesses from the more deprived areas. So it's possible that there could have been a potential adverse effect on health inequalities here, but we don't know that for sure. Interestingly, we also did some more in-depth data collection in a subsample of businesses, and we actually went and visited these food outlets before and after the training. And we intentionally sampled to cover a range of deprivation areas. So these numbers aren't quite representative of the overall population. But interestingly, we had no dropouts from any of the businesses that had actually attended the training session. So even those in the more deprived areas still engaged with this type of data collection. Now, these numbers are really small. This is a very, very small study, but I just wanted to illustrate that difference in recruitment and retention across the different SES groups is something to also keep in mind when designing and executing research and when appraising the evidence base. So in line with the research implications, I just wanted to briefly on what could be policy implications, and very similar to intervention development in research. There obviously needs to be care taken when developing policies that once they're delivered, they do not make inequalities worse. So policymakers need to ask themselves how any policy that they are planning to implement, how this may affect the worst areas within the region that policy will be implemented. And they may use different approaches. So they might want to target the most in need groups, reduce the gap between the most advantaged and disadvantaged groups, or again use that universal approach, but say just with that overall consideration, how is that going to have an effect overall on inequalities in health? So finally, I'd like to thank the National Institute for Health Research who funded our systematic reviews and express that any views in this presentation are my own and not necessarily of NIHR. I would of course like to thank all of my co-authors and colleagues, and these are the full references for the publications if you're interested in looking at them in any further depth. So thank you very much for listening, and I think we may have time for some questions.
Okay, thanks a lot for that, Frances. There's clearly a lot of work that's gone into those various systematic reviews and reviews of reviews, which I'll look forward to reading. We've got a few questions to start off with, if that's all right with you. So the first question is from Catherine, and that is basically if you could just expand, I think, in a bit more detail on what the difference is between life expectancy that you talked about and a healthy life expectancy. I think it's just a bit more expansion on that topic.
Okay, so life expectancy is quite simply how long a person's life is, and then before they die, before death. But healthy life expectancy is the length of time that a person is considered to be in good health. So once a person goes beyond that healthy life expectancy and goes into unhealthy life expectancy, that's when they're considered to have quite a low quality of life due to various illnesses and diseases. So this is why it's sort of really important to that difference in that healthy life expectancy between the two groups, because obviously it does show in the more disadvantaged groups that they do spend longer in their later life in quite an uncomfortable sort of situation where they've got various sort of conditions that would lead to a poor quality of life.
Okay, thanks for that. And I think that relates to the next question, which is I think it relates to the measures that were involved in your systematic reviews and how might they impact on findings, because obviously socioeconomic status can be measured through various different means. So I wondered if that impacted on findings at all.
So there's various different kind of proxy measures of socioeconomic status. So I mean, some of the ones I've talked about are education, and then we've got occupation, and then you have the sort of area level deprivation measures as well, which consist of various different indices. So for our review, we quite crudely included kind of any proxy measure of SES. We didn't really distinguish between them, so that could be considered a bit of a limitation of the review, because there will be slight differences in the outcomes depending on the measure that's looked at. I mean, some of the international studies showing some of the international data showed that actually using one measure did show a stronger association than another. So in the future, we hope that as we can increase the sort of evidence, the evidence base, we might be able to distinguish a bit more between how these measures were or what measures were used for different studies, and actually make more sort of thorough comparisons between those that have used similar measures against those that haven't. So it's just something to consider, though generally the trends tend to be similar depending on regardless, of the measure used. It's just they're not so exact and comparable.
Okay, thanks a lot for that. And I think that relates to the fact that, relates to another question on, you said that we needed to expand the evidence base, and this is a sort of personal interest as well, I suppose. But also, I suppose at an environmental level, there isn't much of it, but how do we improve the quality of that evidence at an environmental or policy level, in addition to expanding the evidence base? I
mean, I think again, the way we looked at it was possibly quite a crude way, because we were including basically any type of intervention. We kind of assigned the same sort of quality measures on every different type of intervention. And the nature of an evaluation of a more upstream type intervention, you're not going to be able to do a sort of perfect randomized controlled trial on that type of intervention. And I don't think that's a bad thing. I think perhaps for those types of interventions, we need to think of how we can conduct suitable study design, studies using suitable study designs in the best quality or the best way that we can do those. So I think, again, ideally, we wouldn't necessarily sort of assign the same quality measures when comparing an individual level intervention against an environmental level intervention, because we just know that there are certain study designs that are best used for those more upstream interventions, which can still be done well. And I think can still give us some useful data, but it is very unfair, I think, to make those direct comparisons.
Okay, thanks for that. We have got a few questions coming in now. So we've got one from Anya, who's thanked you for your presentation, but also said, what are your thoughts on how we can encourage studies to be powered to examine the differential effects? In her research, she's found that differential effects were reported, but perhaps they didn't have the power to in the data, which leaves us vulnerable to perhaps misestimating those effects. And I think that's potentially why people haven't gone that extra step in their analysis.
Yeah, and I completely agree. I think that I think it's probably a genuine reason why people haven't gone that extra step in the analysis. So I think there's kind of two approaches that maybe we can look at, and obviously the ideal is to really go back and for new intervention studies that are being developed, is to really take that time to design them, and to potentially, you've just got to look for bigger studies that are of really high quality, that are able to measure all these different elements, which of course is going to sort of lead to looking for, needing bigger funding. But I think really strong studies will attract that funding. But the other thing that I'm quite interested in is potentially sort of pooling data and looking at sort of individual level patient data or participant data that potentially we could pool to sort of add strength to those sort of smaller data sets, and potentially we can sort of put these together to create sort of larger data sets. Of course, so there's lots of difficulties involved in that, but I think it's definitely something worth investigating.
Yeah, okay. And I think from a special interest group point of view, it's just to highlight for those who are potentially new to socioeconomic inequalities or do have an interest in that, we are, as a group, putting together a position statement on the different measures of socioeconomic status, how you could use them, and the pros and cons of using them. So that's a shameful plug for the group, but that will be coming out, so do look out for that. We've got two more questions. One is around the fact that in the UK, the NHS is free, but then in other countries, the cost is obviously fairly high for healthcare. So I think the question was looking around how SES had played a role in, adjusting in these studies from different areas, perhaps. Yeah,
and as I said, the majority of our studies actually did come from the USA. So they're in that system where they don't get free healthcare. So there is a little bit of difficulty in the sort of generalising those to other populations. But so I think, again, that could be something that could be explored in the future, sort of looking at these real differences in the health systems. And actually there's the review of review that I mentioned. That's part of a wider programme of work that's being conducted across Europe. Sorry. It's been conducted across Europe, and that's actually looking at different health systems across Europe and comparing that with the USA, to see how that explains various health inequalities that are seen in the different countries. So again, that's some more work to look out for. It's not something that I've been personally involved in, but again, that's a little plug for some future work that's coming out there.
You've been very busy.
That wasn't me that was involved in that, but yeah, I know it's going on.
Okay, all right, and the last question, I think, relates to a type of intervention. So they're saying, is it possible that we can give similar health education interventions among high and low education levels? And what kind of education are you suggesting if there's some type of education intervention?
Yeah, I think that, again, so I think this is something that has to be considered with some care, because I think that the problem with, I guess, these targeted interventions that are just targeted at these sort of low, more deprived groups is that problem of a kind of stigmatizing those groups even further, and especially if these groups are overweight and obese, which is kind of like gets a double stigma attached. So I think that in intervention development, we do have to be careful to try and ensure that these interventions aren't sort of noticeably different, and so I guess it's getting that balance between what is applicable to a wide range of population, and again, sort of that delivery of intervention. Now everything is so much more digital and online and sort of phone based, and that doesn't necessarily mean that it's not suitable for lower SES groups, because I think they all engage with all of this technology. So it's being aware, and this is where I think, again, good development and doing that kind of groundwork when developing interventions or education programs, if that's what you're interested in delivering, is actually doing that groundwork with your target population, and finding out what would work with them, in having that sort of PPI, that participant involvement in developing interventions, and I think that's the best way to ensure that what you develop is suitable for the group that you're wanting to engage with.
Perfect. I'll remember that. If I think that's it in terms of the question. So if we were in a seminar room, I'd give you a round of applause and ask
I think it's spot on time as well.
Yeah. But we just want to thank you from ISBNPA, because you clearly put a lot of time into those studies and time into the slides. So it's a special thanks from the special interest group, and also those that ask questions and engage with it as well. And I think it will be online later. So for anyone that's has contacts in this area or thinks it would be of interest to colleagues, then please do share the video link, which I think will be online on the ISBNPA YouTube page. So thanks a lot, Frances.
Thank you very much. It's been a pleasure.
Perfect. Okay.